So I'm going to basically pick up where Pauline left off at the board of the 30th of November, where she described an NHS that was better prepared than ever before for winter, but risks about a potential lack of capacity and flu levels. So I just want to talk you through what's happened since then, how the NHS has coped in a bit more detail, building on the comments of Dido and Ian, and flag some of the learning we've got, and try and, in the throes of a media maelstrom, try and set out where we are in terms of how we compare to previous years and how the system is doing. Dido and Ian have both mentioned it, but I've spoken to a number of staff over the past 2 weeks, and I think we need to acknowledge not just the huge work they've done, but the huge amount of pressure they've been under, which does feel relatively unrelenting to them. I spoke to 130 emergency medics in Birmingham a couple of weeks ago, and there was a real sense of enthusiasm continuing to deliver great patient care, but that they needed to do more. We need to do more to support them, and I think that's something we really need to build on over the coming months and years. And I think it's important to reflect sort of on what the system has actually achieved. So if you look at Q3, so the period from October to December, it's the first time since 2009-10 Q3 performance has improved year on year. So looking to halt the decline. The number of 12-hour waits after a decision to admit nearly halved between Q3 this year compared to Q3 last year. And there were more patients seen in Q3 this year than any time in the history of the NHS. So in the long-term run of things, there has been a significant, I think, step change, as the graph in the paper shows, in trying to halt some of the decline. And we went into the period at the start of December with some of the important work we've done over the course of the year leading up to that, starting to show some impact. So delayed transfers of care were down, freeing up about 1,500 hospital beds. Now that was lower than the ambition we set ourselves of 2,500, but for the past 5 years, you normally saw a 12% decline in delayed transfer of care. We saw a 12% improvement over that period, so that's something to be noted, and that's testament to a lot of the good working across health and social care. The vast majority of trusts had primary care streaming in place following the announcement of £100 million in the spring budget. And NHS 111 calls, about 40% of calls get a clinical contact. So that's some of the broader transformation work which Pauline always highlights to often show some impact. And since the start of December, there have essentially been 3 periods of pressure with different things happening, which we've undergone. So in the period up to Christmas, we had quite high demand compared to historic terms. We had challenges of cold weather. We were about 2 degrees colder on average this year compared to last year, which led to higher respiratory conditions. And our bed capacity supply did not particularly change through the course of December, so we had a relatively static position. The budget monies, which were announced on 22nd November, took a bit of time to flow through, hadn't impacted by then, and performance declined. And that's why, as Ian flagged, at the sort of just ahead of the Christmas period, the National Emergency Pressures Panel met and provided a steer to the system to look to reduce elective care to try and cope with the pressures the system was facing. And I think it's just worth flagging there that this is something that trusts do on a monthly basis, look at how they balance elective and non-elective care, and a number of trusts are already planning to do this. But I think it's the first time you had alignment from all the clinical bodies providing a single message that this is the right thing to do in the clinical interest of patients, and I think that's quite important for systems. So that was the first period. The second period, sort of Christmas to the first week in January, where we saw further spikes in demand, really high levels of things like ambulance arrivals, and flu started to appear. Supplies started to improve with beds starting to come on stream, but performance continued to decline. And we were in a period where the National Emergency Pressures Panel met again at the start of the year and felt that we needed to extend the elective reduction through to the end of the month to try and provide additional capacity in the system. And since the first week of January, we've started to see signs that pressures have started to ease compared to what happened in the preceding 6 weeks. That's not saying pressures have eased significantly, but compared to the preceding 6 weeks. So on average, at the start of January, we had about 2,000 more beds open each day than at the end of December. And we started to see demand in terms of ambulance arrivals and handover delays starting to reduce. On the other hand, we did see flu numbers increasing and continue to increase. We've got the biggest impact on hospitals since 2010-11 in terms of hospitalisation rates. And that's important because, on average, a non-elective admission with flu spends about 2.5 days longer in hospital than a non-elective admission without flu. So we started to see the number of patients waiting more than 7 and 21 days increase. So whilst we've got the benefit of in easing off of pressures and more supply, much of that has been taken up by the increase of acuity of patients that we're starting to see, particularly driven by increase in flu. And the latest position on flu, and we'll get more data tomorrow, is that there are some early signs that we're reaching the peak of prevalence of flu. What the question we don't know, and one thing we need to watch very carefully, is how long that peak will last and the plateau will last. So the NHS seems to be coping relatively well, although it's important to know that it's quite variegated across the country. Ostensibly, the closer you are to the north, the bigger flu is a problem for you. But we need to keep watching that really carefully. So in summary, has been and continues to be a really challenging period, and a huge testament to our staff. And as Ian noted, I think the work of NHS and E together over the past 6 weeks and over the year is more aligned and more intensive than it's been before, and I think it's been really valued by systems. We do need to watch flu really carefully over the coming weeks and ensure that some of the benefits that we've realised over the past few weeks are maintained through the half-term period in February, which is sort of the next point at which pressures do start to spike. And we need to learn the lessons from this year and start planning for next year, which we've already started to do some thinking of. I think the focus on transformation areas, which Pauline continues to emphasise, so trying to continue to improve our out-of-hospital care services, continue to improve the integration between health and social care, as well as looking at how we pair in our acute providers and other providers and how we sort of get that operational rhythm really flowing ahead of the key pressure points through the year. That's sort of a summary of where we are.
Anything you want to add in before opening it up?
No, I think it's been said. I think we can open it up.
Richard, you had some winter questions.
I had a couple just to kick things off. My interpretation of reading all this, Raghuv, is the increased pressure has been broadly counterbalanced by better planning, leading to performance that's sort of roughly where it was last year. So the planning has counteracted an increased pressure in the system. There's two questions, I guess, flow from that, looking at the national level numbers. First one is the distribution of performance across organisations, because I always have a slight concern that a national aggregate number can hide some quite big differences. So have we really seen an impact, particularly in those areas where we were worried, in their performance improving? So it's not just the best have done even better, it's we've actually dealt with the worst as well. It's question one. And question two then links with your comment about what Pauline said about the transformation work. We're not out to winter clearly this year, but looking forward to the next winter, there's clearly a limit to how much just better planning can counterbalance increased pressures. A question about, have we, you'll always get a bit better, but have we sort of done that this year? And if we're going to avoid deterioration next year, it's really got to be a focus on the transformative stuff, not just doing the same things better. So, variation and just thinking about next year on the transformation side.
So I'll take both of those to start with. So on variation, I think it's fair to say that variation is still pretty stark between providers. So it is a slightly different group of providers at the bottom and a slightly different group of providers at the top, but there's still sort of a delta of about 25% if you look at the monthly figures. That's not to say the efforts of focusing on some of our most troubled systems haven't shown benefit. So you'll remember from conversations we had, trusts like Medway and Hull were perpetually at the bottom 2 years ago, and seen some significant improvements, largely down to the great work of the leadership teams there and support they've given. And just over the past 7 or 8 months, you've got trusts such as Gloucestershire and Colchester, who were really worried about at the start of the year, have seen consistent performance in the 90s, but they have been replaced by other trusts. And I think, and it probably links to the remark that was made earlier about the focus on those systems where we have lots of interactions with. There are certain systems, King's was mentioned, Worcestershire, where they have long-standing perpetual problems, and I think you're right that better planning has helped stave off some of the further decline that we've seen trending over the past 5 years, but we haven't been able to turn the corner yet with those systems and significantly drive improvements. And I think that's partly because some of the challenges in A&E are linked to these wider challenges these systems face. So a much more aligned position, I think, will only benefit us in urgent emergency care. And on not just better planning, I agree. I think there is a way to go in terms of better planning. There are things we can do better. The 2 things I'd flag. So almost, why did it take a national clinical panel to advise that you should have far less elective work in January than non-elective work? That's how can we build that into our planning over the course of the year and understand the pressures that are going to come. I think Jim was very fond of saying we know the 27th of December and the 3rd of January are the worst days of the year. Why do we not plan for that better? And there isn't a great sense that people plan significantly better across the country. And I think a focus on, for inside hospitals, length of stay and those patients who are waiting more than 7 days and 21 days in hospital to discharge. That's not just problems in social care, but that's looking at the processes inside hospitals. So I think there is planning there, and that part of that is also transformation as well. So I think particularly over the next 12 months, there's big progress to be made on linking up 111 with the ambulance service and 111, putting 111 online. Really pushing the implementation of the ambulance response programme and the new standards there, which has only just started. I don't think we've seen the benefits of that yet. And the development of a more consistent approach outside hospital to minor injury units and walk-in centres, because again, you hear they have capacity, but people don't know to use that. So, and that's not a position we can be in given the constraints we're under.
I've got a couple more, but I'll let other people come in now, Dada.
Ruth, did you want to come in specifically on this?
No, this is about winter, but
So Sarah first.
So one of the things I was going to ask you've already now touched on, but let me just explore it a bit more. I was also impressed that we felt we needed to announce that we were going to delay non-urgent operations in January. The logical question would have been why had they been booked in the first place, and that having to make an announcement publicly perhaps sets more hairs running than if there just had been better planning in the first place to reduce that level and to deal with those consequences. The second thing is I'm always surprised that we need to say that we're encouraging more vaccination of NHS staff. I mean, I have been sitting on NHS boards for 10 years now, and every year we have the same conversation. In that this was a year where there has been a real flu impact, particularly in the north of England, it would be worthwhile actually trying to collect some data that says this was the impact on the trusts that didn't manage to get vaccination right across the board, you know, whether they actually lost staff days. Because I think we need more evidence to get the numbers up, and we should take this opportunity to look at it.
So I'll just come back briefly on those. So on the National Emergency Pressures Panel, I think evidently you're right that these things do happen, but I do think it's the first time you had the Royal College of Physicians, surgeons, general practitioners and nursing all giving the same message, and that alignment of messaging I think is really, really important and does provide a bit of that sort of almost permission for certain systems to do it. And I think one of the key things that they recommended was that it should be done to free up, where you can free up capacity for non-elective care, and they prepared some quite directive examples of how that can be used, such as turning outpatient clinics into hot clinics for respiratory conditions and using that in a more active way. But again, we should try and build some of that into our planning for next year. And on staff vaccinations, so Kathy might want to come in on this. So we know, unfortunately, the data for December is published tomorrow, so I will make sure you've got that when we've got it out. But we know at the end of November, staff vaccination rates were about 4% higher this year compared to last year. So I think some of the push has had an impact. We also know there's a huge variation across the country, particularly in some of our community and mental health providers where the rates are usually lower. I know Kathy and Ruth have been doing a lot of work to try and highlight where that variation is and offer nudges to try and increase that. But I don't know, Kathy or Ruth want to come in on that?
yes, I mean, I think as Raghuv said, it has been better this year, but the variation's huge. I think, and what we've been trying to do is capture what the good ones have done to share with the ones who haven't got so far. And I think that's a really important part of all of this. And I think that as we go think about the next year, and this one's not over and we're not stopping on that piece yet, of course. As we go into next year, I think we need to get even further ahead of this and think about what are the strategies to make this really, very, very high in, because we get places that get over 90%, right
Yes.
up at the very top.
Yes.
And then you get somewhere else that'll be sort of in the 20-odd%.
Yes. So to be able to
Um,
say at the end of this year, when we look at the numbers, actually this many staff days were lost because people had flu. It's inexcusable.
Yes, but I think that there's a lot of debate about exactly what the value is, and there is a big value in not infecting the patients and so on. So I think it's multifactorial. We need to look at it in the rounds. But there's a lot of work has gone on, and some of our staff and other staff elsewhere have worked really hard on this particular aspect.
Okay.
Yes, just several things. I'm a buddy arrangement with West Herts, so we've been working very closely with NHS England's team and NHSI teams around that. It'd be useful when we do the review about, can we review how the budgeting arrangement has gone as well, from the trust perspective as well as ours, but in many ways a bit like we've been wanting to do our joint working more focus. It'd be useful to see how that works. I just know that whilst the Emergency Winters panel made a decision around mixed sex accommodation, which was the right thing to do, it does impact patient experience, and I don't want us to think that it's all about safety. It is about the whole, as the Lord Darcy would say if he was here, it's around the three elements of quality. So under Sarah's leadership, Kathy and I are going to do a review of the whole quality impact of winter, and we'll do that in time for April, which will include patient safety but also patient experience, which that's really important. I spent Christmas Eve, I spent Christmas Day actually in A&E as a relative, and I saw firsthand, and I've also seen firsthand and heard firsthand from many, many directors of nursing. It isn't just the clinical staff that are working hard, they're working superbly hard. It's a 7-day, 24-hour event for these people providing leadership of our departments, but it's also the clinical teams in community organisations, mental health organisations that's supporting the urgent care pathway. So I'd like to draw thanks to all staff, whether they be porters, your directors of finance, all staff across the whole of the NHS, not just our clinical colleagues who have worked their socks off over this period.
Yes, here.
Absolutely.
Kathy and then Glynis and Sigurd, sorry.
So just building on what Raghuv said and what Ruth said, I think there's absolutely no shadow of a doubt that people have been working incredibly hard out there. What I would say you can see firsthand in terms of the planning and the system working together, that has worked much better, I think, than I've ever seen it working before. I joined the calls every day, spent time at Barts, went round all the sites, etc. And what is really clear is that the whole system is working. So when stuff is happening, so in other words, when an organisation is under huge pressure, there is a mechanism whereby they can actually get together across a system and make a difference. So I think that feels much better. But what I'd also say, which is harder to see in the data, is that what I have been hearing from many medical directors and so on out there is that there is a high degree of acuity. In other words, there are some very sick patients. And I think as we look back at this winter, fairly soon we will be in a position of gathering the data, looking at it in more detail, and using all of that in our planning and our thinking for the future. Because whilst absolutely there with the transformation, I think we need to think about, what I've heard from some people is, the patients are so sick, there was nowhere else for them except hospital. Now, when you're in that position, you have to make sure that we plan so that we take that into account. You might have another winter in which that isn't the case, but that the population is getting older, is developing more conditions. And then when you add a respiratory infection, which is what the problem has been, not just flu, but respiratory disease on top of it, they become really very unwell. And I think that's one of the things that we've seen. And we'll only really know how to categorise that afterwards, when it's all been collated and coded and all of those things. But the feel is that people have been, on the whole, quite unwell. And that's a really important sort of, granular thing that's out there beneath the figures, if you like.
Sigurd.
Thank you. We've heard some good reporting on excellent planning, better obviously than in previous years, for dealing with the situation, which has, as I think Richard or someone said, meant that although the demands on the system were greater, we managed to cope surprisingly well. We've also, I think, heard of some necessary decisions being taken about mixed sex and delaying operations. But in a way, neither of those should have to need to be done. And I would like to see us, even as we recognise that we are probably going to need to do some serious planning again for next time, to also in parallel undertake some urgent work and maybe invite the teams who are looking at this to come back. I don't know what the timing would be, but in ample time before next winter, so maybe July or September, to let us know what's being done on the one hand to transform pre-hospital care. We've heard a lot about a lot of very good, very sensible ideas. For example, I don't understand why all 999 call taking and 111 call taking, isn't integrated. I think a lot of it is now, but I don't know what the proportions are. The logic of integrating them is obviously that you can then play for time, if I can put it that way, with less risk to patients, because if you at one point when you're trying to deal with the thing on the phone, realise that you actually are going to need to send an ambulance, all you have to do is hit the button. You don't have to ask the patient to call another number and so on. And so it allows you to be much more whole in the way you deal with it. So anyway, I'd like to see all of that being properly looked at and maybe to come back and report to the board at the right time. Similarly, on the other side of the equation, greater integration with social care and greater use of bed capacity of that kind in the system. All of those areas where we're doing good stuff, but I'd like to see it all pulled together for the board to see in parallel with the planning for the emergency that sadly we will probably face again.
When are we planning to bring a formal review of management of winter to the board?
So I think last year we published the review in about June, so you need to wait for all the data to flow through probably until that period, and it came to the board I think around that.
So all my operational experience would say you need to capture the learnings much faster and have an initial learnings discussion while it's still fresh in everybody's heads and hearts, and then add in the data for the forward planning. I'd like to have something come much earlier than May, June. Looking at wiser heads nodding, there's agreement for that.
In March seems like a good... You've got winter done just about, I think, Kathy, by March.
It depends.
But I'd agree entirely, Daddy. I mean, I think you do need the data at some point, but actually you also just need that sort of fresh in people's minds about what
More
happened.
stories.
It's just to come in there to say that the operational guidance will have a timetable that we'll be working to, and this year we're asking for the winter plans to be prepared in much more detail alongside it. So in previous years we've had operational plans, and then after the start of the year we've had winter planning, assuming that it would be consistent with the operational plan. We're going to do all of that in parallel this year, so and build in the learning and some of the things that Raghuv has talked about.
As part of this process of understanding a bit better what's happened and understanding quickly, I think given what we've said about the significance of variability in the effectiveness of both the development and the execution of the plan, I think that we really need to understand better what the basis of that variability is, part of the analysis. Because actually if we have the level of variability that we do, it may actually be an answer to Richard's first question, because he juxtaposed these things as two questions. It may just be that you don't need transformational stuff, you'd need more of the same if you can cope with the variability. But we don't know whether we can cope with the variability through that mechanism, because we don't know the bases of the variability. So I would be really looking forward to a report that told me a bit more about that.
I think that's what sort of when I talked about what we can do, not just in transformation terms, but sort of the way in which hospitals and the system plan and then use their staff in a way to meet the demands. I think there is more to go at, and I think a lot of that does drive variability between systems, and that's also variability between systems, but also in systems between shifts, sometimes between who is on at a weekend compared to, and so what are the basics? And I think that is something we want to do more on for next year, most definitely.
And you would want to make assertions about that on the basis of really solid evidence, wouldn't you?
Yeah.
Rather than intuition.
No, and we have got some emerging evidence around it.
I had a couple just on. Sorry, to come back. So a couple on particular on some of the numbers in here, just to get.
Right.
I want a comment, one's a question. So question one is about particularly the growth in 0-day admissions, which is in on about 6%, something like that. And I guess a question for both of you on this: is that because the hospitals are full? So essentially, this is not things that in the past would have been 0-day length of stay, but they're 0-day length of stay because there ain't anywhere for people to go overnight, or is it a change in sort of clinical approach? Because that's one number that really stands out as very different, I think, from any other year that I've seen. And just linked with that, there will no doubt be comments about that means that the pressure maybe hasn't been as great as we thought. But my presumption is a 0-day length of stay still needs doctors and nurses looking after people for that day. So I think we should be careful that we don't read the wrong type of things. Can someone explain to me what's happened with 0-day length of stay? Is it just we're full?
It's not 0 day ever, is it? It's maybe half a day.
Yeah. Well, it's not overnight, I think, is it?
So do you want to give you first, and I'll follow that with you?
Yeah, so I think I think there are two things happening in that. So one is that it is we are more full, and so you may get a rise in those sorts of emissions. But so that's a sort of negative side of looking at it. The positive side is we've been pushing really hard over the course of this year, the increase in assessment units and ambulatory emergency care. So actually we want to take people out of the emergency departments, do some rapid treatment, rapid diagnosis and treatment, and send them back home as quickly as possible. So that will also contribute to some of the rise. I think one of the things we need to look at as part of the early winter review, as well as the is once we get the data, is understand sort of the size of those two factors.
So your presumption is, in a sense, is that this was planned for because we knew we'd be full, as well as the sort of clinical reasons for this. Could I ask Kathy as a...
Even better.
Well, I'll ask you as Chief Executive, but Kathy as a doctor to explain it to me.
Well, I think it's. I think you do have to really understand it. You need to look at the models that have been put in place, because I think, as Raghuv says, we are encouraging a turnaround faster in assessment units. An assessment unit expects to have a low length of stay, and in fact, for some of them, they really need to have that movement. Otherwise, they can't take the next one. So, I think we need to look at what's different about that and do some more analysis. And I think in some ways that people are more efficient at getting things to the patients. So at the front end of the pathway, which does help them move on. But I think it's very difficult at the moment to say that it's because of the full, and the implication you have is that they're going home when they shouldn't. But I don't think we've any evidence of that, and I think we'd need to look into that in a lot of detail.
It's just one other thing I think when Glynis talked before about understanding this year, that because that feels different, really. That's the one bit, particularly on the statistics side of it, that I think we just need to understand a bit more.
Yeah, just to add, I think we absolutely need to have a further look at which of the two dynamics you talked about, probably which are both there, are prevalent. But I think it is worth absolutely saying that by and large patients that get into that category are going to have a fairly significant amount of clinical resource, diagnostics, clinical input, nursing input. So these are ill people that are getting the benefit of a lot of clinical care, albeit for quite a short period of time before a decision is then taken that they can move on to a home-based setting or whatever else. So it's certainly at least a thesis that that is a better way to look after patients than might have been a previous short stay. So I think we absolutely need to look at the balance of these things, but also reflecting that it takes place in the context of occupancy levels that we've seen running in the mid-90s for an extended period of time this winter, which is also an issue that we need to have a look at in the wash-up, because occupancy levels have been very high, meaning bed availability has also been low.
Ian, would we have data on return visits of those people?
Yes,
Yes.
And
Readmissions.
Yeah, we do.
could we
Yeah.
could we unpack that
Yeah.
a bit?
Elizabeth,
Yeah.
you're going to...
Yeah, that's one of the points I was just about to raise. So when we get the data and the information through, and particularly for January, which will come in February, where we look at what happened through December as well, we look at readmission rates. So that's something that we track. So if a hospital, if there was a patient that returned to hospital within 30 days, that actually signals, and we can look at those patients.
And then we would know if they'd been one of these the
A
patients
short
who-
stay, yeah.
Well, not short stay, but 0 day.
Yes,
Yeah.
we would. Yeah.
I'd add to that, the other piece of data, which is readily available, is those who call 999 within a few days of being discharged in this way.
Yeah.
That data is readily there, and that's quite a red flag if we see that happening a lot.
Yes.
The comment on the number, the one comment I was going to make, it is, a tad disappointing that with the winter monies, there's a line there saying 50 million is being held by DH for further discussion.
Treasury.
By Treasury.
Treasury.
It's
Holding
Treasury?
it, yeah,
Yeah.
it's Treasury holding it.
Oh, right, it says DH in my paper, never mind.
Don't blame
But-
Not your form of after all.
But it just seems, wherever we are, 24th of January.
Yes. Well, you can never be too careful, Richard.
Yes. Ian, do you want to comment on that? Or?
Clearly, it's in all our interest to get that cash out. I mean, I think one of the things that we need to reflect upon is that we got a fair amount of cash out before Christmas, and that did lead to a significant expansion in supply, which I think we haven't talked about particularly, but we saw, I think, best part of 3,000 extra beds
Yes, on average, 2 to 3
over the
thousand.
system. So we did see the money that went in before the Christmas New Year period lead to a significant supply expansion, which has certainly contributed to the pressure easing as we've gone across January. But yeah, as a rule of thumb, obviously the earlier and the more significantly we get the cash out, the more impact it will have. So I think those discussions need to continue and be concluded.
And I know it's easy to say this and very hard to do, and you have to respect the national budget timetable. Nonetheless, in any other world, making decisions on the money available for winter at the end of November is far from ideal. And I do think it's something that we need to reflect on as part of the review.
I think we do need to look at timing of resources, and certainly for next year, the planning guidance, I think, suggests that people shouldn't be assuming that there would be an extra winter allocation.
Yeah.
The money's in baselines, and therefore that should mean that the resources, when we get the planning guidance, should be the basis on which people plan for winter. So I think the timing issue is partly linked with planning, and going
So
forward,
within our gift
going
to
forward,
change.
we can have, I hope, an easier discussion next year around this
Okay.
table about winter planning, picking up on the earlier points, given the knowledge of the resources that we have to bring to bear, and then ask the question, what is the capacity that will then buy at the time of winter?
Elizabeth,
One more comment. Yeah, just one more comment. So I'm just wondering, for the next winter update or the next set of discussions that we have, if we could also have a specific discussion around GP access and what happened outside of hospital.
That'd be good.
Because I think we focus very much on this area, but I think to look at it, we need to look at it a bit more holistically.
Yes, yes, well said.
Yes.
Great discussion for the joint board, of course.
would indeed. Yes.
Good.
Yes. Any other comments on winter? Well, I think, Raghuv, there is a very clear desire for a early review of winter at our next formal board meeting in March.
Excellent.
And no,
Stuff from my team earlier today. So.
appreciating that you won't have all of the data, but that we could actually
Hot debrief.
have a hot debrief. That's a great way to describe it. Well, thank you, and thank you to Pauline and everyone else in the
Absolutely.
team for the work, because you have also been working round the clock all the way through the holiday period, so we really appreciate
Absolutely.
that. Okay, excellent.
Certain data